Good morning. Can you all hear me okay? Is the audio good? Excellent. I'll tell you what, after that really relaxing session, I'm ready for a massage. So my topic is to go over innovations and insights in healthcare and administration and delivery. But I want to start by thanking SDS for inviting me here to speak here in the Twin Cities. Twin Cities, for me, has a special place as the Hassan family heritage in America starts 60 years ago when my father came to the University of Minnesota for his PhD in chemistry. Courtesy of that immigration, there are now 55 families in the United States of America contributing to this great culture that we have. I think for those that don't know, we should thank those of us that are in the healthcare space and technology space, civil rights leaders in the 60s that helped to open up our immigration laws so that we have more access to immigration from Asia. That allows us to have people like my father being able to come here and having generations of folks that are now both in the healthcare and tech sectors in particular. So I'm very thankful for their shoulders to stand on. I'm going to go over with you that SDS has been a terrific partner with us at Network Health for over a decade. I should share with you that my boss, Corrine Dykes-Johnson, sends her regrets. She was supposed to be here giving this keynote, but you guys get Joe Flacco. I'm the backup. Hopefully I can do that for you, but I'll be referring to my boss because I really enjoy working with a wonderful boss that I'll make reference to during the course of our presentation. Some basics about Network Health. Our mission is to create healthy and strong Wisconsin communities. We are a provider-owned health plan on the eastern side of Wisconsin. Our mission is to be a local, reliable partner delivering an exceptional health plan experience. We are owned by Froedtert Health, which, if you've been watching Becker's, is now Froedtert ThedaCare Health. Two of the major health systems in eastern Wisconsin have merged. Medical College of Wisconsin is part of that mix. We are owned, but we're still independent. I know some of you may struggle with being a health plan that's owned by a hospital system where you're more of an appendage of the hospital system. We take great pride in the fact that we have an independent board as well as independent function as a health plan, and that allows us to be able to do things in a more innovative way. Under my purview, I have got clinical quality, population health, as well as utilization management. I'm proud to report to you that we are a 5-star Medicare Advantage plan for the last 3 years. In about 2 weeks, I'll be able to say 4 years in a row. We are very happy about that. I've got a great team that gets to work with me. We are also a 5-star NCQA plan, one of only 2 in the entire country that's achieved 5-star NCQA status. For us, we take great pride in that. We've also got a large commercial membership, as you can see. It's about 25% of what we do, including a lot of state of Wisconsin employees. The state of Wisconsin also measures us on quality. Currently, we're at number 2 in terms of quality by their measurements. I'm gunning for number 1. But the bulk of what we do is Medicare Advantage, and we take a lot of pride in the care that we provide to our Medicare Advantage members. So a little bit about Network Health. Corrine came to Network Health back in about 2016. It was a plan in trouble. Declining revenue, culture that was toxic, and there was concerns about not being able to pass audits. Corrine came in, laser focus on compliance, audit, financial stewardship. I've been really impressed coming from a clinical side to see just how much attention is paid to compliance and audit. So much so that when I see news about people getting fined for doing things that are wrong, you start to wonder, how'd you get away with that? Well, where's your audit department? But I think that we've really been able to clean up our house and really have a diligent attention to detail. That's also required some change in culture for our leaders. You heard this week about having growth mindset leaders, and that's what we've got in our C-suite. Folks are very positive, upbeat, and always looking to grow. Guiding principles that Corrine brought in is that we knew that if we wanted to increase our star rating with our members, those that face the members must be happy. So employee experience, especially for our member-facing employees, has been priority number 1, and making sure that happy employees will lead to happy member interactions has been a priority. We've also been able to build up, since 2017, trusting relationships with our provider partners. And our clinical integration program has trusted data exchanges being foundational. Now, just by a show of hands, how many of you have talked with the doctor and told that doctor that they're not doing as good a job as they could? All right? How's that conversation usually go? Usually it's going to be, no. My patients are sicker, right? It's usually, no, you might have your data, but my patients are sicker. So how do you handle that conversation? What we've been able to do is build up a trusted foundation of data that we all agree upon. And I think that's very important when you have a partner like SDS to be able to have that data back and forth so that we're able to build that foundational database of trust. That's taken time. It's taken diligence, it's taken regular meetings, it's taken drilling down on the data for us to be able to get there. But now we're at a point where we can really have deep dive discussions even at the clinic level to say, why is this clinic in this particular city having such difficulty with colonoscopy? Can we get those numbers up? So we've got the ability to drill down and have conversations with our provider partners to do that. As a result, we've had improved quality metrics that's come forward, and this is really made for us to be able to have a stronger presence when it comes to our Medicare star rating. In that way, we've also had to have a cultural shift in our quality department. We've got a culture that's very positive and upbeat, and again, having leaders that are growth mindset has been very helpful for us to do that. We also, the last year, have incorporated what we call the Network Health Way, which is kind of who we are and what we're about as a member of Network Health. One of the things that we have on that is being spirited. We like to have fun at work and making sure that people understand that's part of what we do. Now, a little bit about me. As you heard, I'm a primary care internal medicine doctor. I was in a busy suburban internal medicine practice for the last 25 years. During the course of that, I was tapped. If you ever have someone that's going into joining a practice, ask them to join a practice that has physicians at every decade of life. I was very blessed, where I had 60-year-olds in my practice, 50-year-olds, 40-year-olds, and 30-year-olds. My 60-year-old partner taught me how to buy a car. I didn't know how to buy a car when I was coming out of residency. Little things like that come forward that you want to be able to do. He also tapped me on the shoulder and said, hey, listen, in our group, the culture is that you serve on committees. And I think that being able to do that allowed me to have exposure to hospital administration. I had a hospital president once tell me, Dr. Hassan, you do a really nice job running meetings. You can tell people to shut up or they almost want to thank you. I think he meant that as a compliment or just recognizing I'm born and raised in New York. But I think it's important to be able to have that experience of both how to run a meeting and how to speak at a meeting and also when not to speak at a meeting. Being able to understand how to navigate those waters. With that, our practice actually went from being a private practice in suburban Milwaukee to being a hospital-owned practice. I'm sure a lot of your other communities have experienced that in primary care, where hospital systems have bought up primary care practices. My boss, Corrine, was actually our first meeting there. She helped to negotiate the deal where we went from private to owned. She kept on transitioning to leadership roles, and along the way, she kept on tapping me on the shoulder to say, hey, I think you'd be good for this. And I think that brings up something very important. It's important to have an advocate that you've got that's trusted, that is always looking out for you. So always try to find and identify someone who's your advocate. The transitioning for me went to the hospital admin side, where I was Department of Medicine chair and then Vice Chief of Staff, and then Chief of Staff would have been the next step, but Corrine tapped and said, hey, do you want to come over and be the Chief Medical Officer on the hospital side? And so I was in charge of hospital quality for 2016 through 2021. Ended up leading a hospital through the pandemic without a hospital president. So I had to eventually serve as the hospital president as well. And along the way, because there wasn't enough controversy in my life, I decided to join the local school board as well. So during this transition, Corrine then tapped me on the shoulder again and asked, hey, do you want to come over to the payer side and see how things are like as a CMO for a payer? Again, Corrine is very insightful. She sees that her CMO is approaching retirement, and she wants to do retirement planning, and she comes and talks with me about this. I, of course, told that insurance companies are evil, and I don't want to have anything to do with being on the payer side. And she, being a good salesperson, said, okay, let's have you just try and dip your toes in the UM pool. So she had me do utilization management for a little bit to try and see, can I look at what we do from a UM side? What I found is that it's actually pretty evidence-based, it's data-driven, and as a primary care doctor, you can better appreciate, okay, how can we get to yes more efficiently for the doctors? And I wanted to always have that as a practicing clinician, that knowing that what would frustrate me at the bedside, I want to make sure I try and fix those problems. And so being able to collaborate with payers to help make that better has been part of my MO. In addition, you can identify outlier physicians and being able to have conversations with physicians that are outliers to be able to show them opportunities for improvement. If you have, let's say, a full gamut of spine surgeons, and 80% of your spine surgeons tend to do the same procedure within this bell curve of cost, but you've got a couple of spine surgeons that tend to have a much higher cost, a much higher hardware utilization, you need to talk to those spine surgeons and say, hey, wait a minute, how come you, compared to your peers, are such an outlier? And being able to have a quality conversation, that by the way is something I suggest everyone do that is in a hospital system. Take a look at your spine surgeons. But looking at that, I think, is an important area just for us to be able to see. Now, making this transition, all my physician friends, of course, think I've completely gone dark side and turned into Darth Vader, so I have to have some credence with them. I like to lead with, we are a health plan, not a health insurance company. And what does that mean? That means that any profit that I make goes back to the hospital to reinvest in the community. And I say it again to them. I'm not beholden to Wall Street. Any profit I make gets invested back into the community. I think it's important for us to emphasize that from the payer side, is that our goal is to do right by the member and to do right by the community. So, topic for today, the role of AI and automation in healthcare's future. For me, as we're planning for this discussion, I saw it as more a question of, can we look at what's going to happen to primary care? Sit back and think to yourself, what's the ideal primary care visit that you've had? Well, let's ask another question. How many of you have been to see your primary care doctor in the last year? Okay, very good, okay. How many of you took like 6 months to get in? That's probably another. All right, so think of the ideal interaction that you've had with a primary care doctor. What are the qualities that make that up? I would submit to you that number one is clear communication. Second is someone who took time to explain things. Next, you've got making sure that you understood what the next steps are for your care. So it's communication, explanation, and navigation. Those are the big three things that we want in a really good primary care doctor. But that whole bricks and mortar primary care model is under assault right now. You've got telehealth, you've got storefronts like One Medical, you've got the mall kiosk or the retail kiosk at the pharmacy of choice across from the pharmacy counter. You've of course got people diagnosing themselves on the internet. And actually you've also got, even in the bricks and mortar, less MDs, more APPs. Now certainly PAs and NPs have a role in the primary care delivery model. But the reality is it's hard to find a general internal medicine primary care practitioner. Our group looked for 10 years. We could never find someone that wanted to go from internal medicine residency to come join our practice. And frankly, you could say I'm part of the problem because I left primary care internal medicine. But we're dinosaurs. Folks that want to go into primary care internal medicine, it's just not there. So we're going to have to ask the question, do we need better incentives to have people go into internal medicine primary care? Those of you that have kids that have been in elementary school, have you been able to experience the teaching model where you have 2 teachers team teaching? And usually they're young moms that are able to share the load of teaching. We should think about that from a primary care standpoint. Can we have folks go into primary care where you're 1 week on, 1 week off? Because clearly the hospitalist model at the hospital has some draw. People like that model. So should we be doing the same for primary care? We're going to have to ask that question as systems. We're also going to have to ask the question for hospital systems that, come out and say that they support primary care, they want to be supportive of primary care, but if you look at their financial bottom line, the reality is they're investing in orthopedics, oncology, and cardiology. And the reality is, I am praying for the day where I see an orthopedic discharge summary for a knee replacement that says, wound looks good, patient's counseled on physical therapy, and oh, by the way, we suggested the patient have a colonoscopy. No orthopedic surgeon in my lifetime is going to be doing that. And we need to understand that primary care is going to be the way to do that. How can we better facilitate that? And the way to do that is to make sure we understand that there's a fragmentation of care that's going on right now. And that fragmentation is begging for navigation. And the discussions surrounding interoperability tend to be centered on data exchange for quality, efficiency, and risk adjustment. Hey, for us as a Medicare Advantage plan, that makes a lot of sense for me. I need to understand how sick my members are so I can better act upon what they need. But the reality is, we need to think about going to the next step. And I think artificial intelligence is going to help us with data exchange and analysis and communication prep for navigation. I want to set up my care managers, my condition managers to be able to have targeted conversations, as well as making sure that the last mile of communication is done by a human being. I think that member communication being personal and backed up by quality analytics is what's going to keep us at a 5-star plan. We can also use analytics to guide multi-channel communication to members to assist with navigation. We're 75% Medicare Advantage, so I was always concerned about how much uptake our members would have with smartphones and apps and things of that nature, because they're on Medicare, they're older patients. What I have found is that FaceTime is my friend, because grandparents wanting to FaceTime their grandchildren are going to become very smartphone proficient. And being able to negotiate that and using that as an in with my seniors is really important for us to have. So from a generative AI standpoint, I think that we want to ask some questions as to what we're doing and where we're going. Analyzing large clinical data sets on medical records to help quantify risk has been foundational for us as a health plan. This leads us to be able to know which chart chases we should go after, and working with our provider partners as to who needs to make sure they've got their conditions documented each year. We are doing a better job of integrating our pharmacy claims with our medical claims and doing analytics on that to be able to better understand our total cost of care. Let me give you a for example. If you've got someone who's chronically ill with a chronic progressive neurologic illness, there are some very good medicines that can be used in some of those scenarios. Let's pick, for example, ALS. Terrible illness, we've got some medicines that can be used for that. But if we can use our analytics to show that the medication, which is very expensive, continues to have utility and at least disease progression abatement, then we can say that the medicine's working. But if you have your analytics telling you that a very expensive medicine is being used and the member is still declining and declining each year, then being able to say to these clinicians to have a focused conversation as to, hey, is this medicine still of utility? I don't want to be directing care as a payer, but I think encouraging conversations just to make sure that we're having the best utilization of resources is important, and we can only do that if we're having analytics of that nature. As member care gets more complex, we're going to be able to use predictive analytics to better predict who's at highest risk for hospitalization and potentially having goals of care discussions. Just by a show of hands, how many of you have read Atul Gawande's Being Mortal? Okay, you should. So if you want to write that down. Let me ask another question. How many of you are like me and have to pick up your mom's phone call in the middle of the day because she has a concern that she wants to talk to you about? Right? We're taking care of our parents. Okay, if you have parents that are potential network health members on our MA plan, which is 5-star, by the way, if you live in Eastern Wisconsin, but if you're taking care of parents that are in the Medicare age group, I strongly encourage you to read Being Mortal. And I encourage you to read that book because it gives you a sense for what should I be looking at from a priority standpoint. I started out talking about my late father. He lived with me for 5 years with his end-stage COPD. One of my pride points was that I didn't have to take him to the hospital because I was able to calm down and kind of make sure we only went when we absolutely had to. But I would also tell you that I wish I had read that book sooner because I would have better understood the conversation to have about what goals of care should be. So if you take one thing away from my conversation today, I would really encourage you to do that. But I think for us as a health plan, I'm encouraging us, as we can predict which of our members will likely have more and more risk for hospitalization as well as chronic conditions building up for them, having them have this book at least be in the family reading circle, I think is important. Once we're better able to collaborate and kind of address privacy concerns, we can also have some discussions about how to better leverage technology in the home. We've all seen that already, right? No one's got a doorbell anymore. Now your phone tells you exactly who's at the door and when the Amazon package arrived, right? Some houses more than others, including mine. But I think that we can also have some degree of monitoring that's going on that can happen in the home that allows us to think about new things that are somewhat invasive, but also somewhat cool. Let me give you a couple of examples. If I have someone that comes home from the hospital, and let's all raise our wrists. How many of us are drinking at the trough of Steve Jobs? Okay, so we've all got this tracking that's going on, and a lot of folks have trackers at home that can be fed into us. If I know that, let's just say, Medicare Advantage Network Health member Muriel gets home from the hospital, and she usually does 8,000 steps a day. But for the last 2 days, she's only done 2,000 steps. That should send an alert to my care manager to call to say, Muriel, is everything okay? Because we know that's a change. Now, that's somewhat invasive of our privacy, but it's something that's very helpful for us to be able to do. Those of us that have motion sensors in our homes, being able to integrate that. If we know that Muriel goes to the bathroom roughly 5 times a day, but now we can show that she's going 10, 12 times in one day, can that then trigger an order back to her doctor to order urinalysis to get a UA check for UTI? Again, invasive of her privacy, but helpful for us to be able to kind of understand what's going on in the home. Where we see as Network Health as there an opportunity here is that we have a lot of members who have family that's out of state from Wisconsin. And they want to know how mom or dad is doing. And they would like to keep mom or dad at home independent as long as possible. Having a conversation under that auspice, being able to talk to folks, say, look, we understand that there's some degree of data sharing that's going on here, but we think there's an opportunity for us to be able to keep people independent at home as long as possible if we have some technology feeds that are coming back to help trigger interventions before someone ends up in the ER. It allows us to work upstream much better. We just have to get over some of the privacy concerns that exist. I don't say we figured it out just yet, but I think that we have opportunity that's here. Forgive me, I still like to use old notes because we used to be in the white coat when I was running in the hospital. I think we're at the very beginning of understanding behavioral analytics, and this is going to lead us to better predictive analytics to better quantify member risk. I was also asked to talk a little bit about strength-based leadership. I think it's really important to understand the strengths of your internal team. We have outstanding internal actuaries in Network Health, and inquisitive enterprise analytics is in our foundation. About 2 years ago, a study came out from the University of Michigan that showed that if you do a natural language engine onto clinician notes that include not just clinician notes, but social worker notes, nurses' notes, respiratory therapy notes, you can pick up on patient needs that exist. Because rarely will someone tell their doctor, look, I'm having trouble getting food, or I'm having trouble getting a ride. But they will tell the social worker that. So they went back through and they mined all the notes, and they were able to come back with a model to show that, hey, we can stratify folks that have transportation needs or they're meal insecure. I brought that study back to our analytics team, and within 1 month, one of our analytics IS experts was able to make an engine internally for us to run on our own patient data so we could stratify what's going on. And I think this is just a really great example of us thinking collaboratively, what's the research show and how can we get that to the bedside? It helps to have partners that are able to do that, and also helps to have a strong internal team that can do that. I think that being able to have folks that are positive but still inquisitive is important to have in your team. You want to have healthy disagreement without being disagreeable as you talk about growth. A lot of this questioning can better point out deficits where you're collaborating with partners makes sense. Also, going with the vendor can make sense. And I think having a Rolodex of resources is always a good thing to have. That for us was very important when we had the cyber ransomware attack in February. SDS was in our Rolodex, and we were able to have just a wonderful interaction. I want to share with you what our VP of Operations shared with me about the interaction with SDS. I would like to share how fast and responsive and accommodating they were to work with during the ransomware attack that happened in February. With SDS's help and coordination of our platform vendor, we were able to get electronic claims rerouted and back into our doors and were ready for processing by March 19th, 2024. This would never have been possible with a large clearinghouse. Their eagerness to jump on calls at all hours of the day and get up and operational was phenomenal. So having personal relationships with vendors that you've had for a while allows you to be able to get to this stage. We've had a relationship with SDS since 2017. And I think being able to really harness that relationship allowed us to be able to recover as quickly as we did. I can tell you that from a network health standpoint, we've got other vendors that come to us looking for pilots. We're currently doing a pilot on falls risk reduction. We've worked on another pilot with our PBM about being able to get automated pharmacy approvals by incorporating data from our health information exchange as well as any data the physician gets to us. That allows us to get to yes more quickly. I think these are important things to do just to have the culture of making sure you're trying new things out. I think as a leader, I also want to give some advice. My wife kind of made fun of me because she found out that I was going to a book club meeting with a bunch of guys. And she said, okay, what book are you reading? And I said, well, and this is actually the superintendent of our school district had invited me to be part of this book club. And so he said, hey, let's read Reed Hastings' story about Netflix, No Rules, Rules. And in there, he actually does something that I've started to adopt for myself. Once a year with my team, I will ask my direct reports, tell me what I should start, tell me what I should stop, tell me what I should continue. Start, stop, continue. I'd encourage all of you to do this with your teams, just to make sure you're getting some feedback as to what you can do to improve. I've also asked my team to really not email on the weekends. One of my VPs would send emails on Saturdays, and I told her, I said, listen, you can't be doing that because then the rest of the team thinks that they have to be active on the weekends as well. Shut it off. I will also tell you that having been through some of the more stressful 5 years of getting through the pandemic and recovering from the pandemic, it's important to disconnect from technology for some time, just so you have some time to really step away. During the course of our last session, which I thought was wonderful in terms of getting into mindfulness and being able to disconnect, you did have a handout that came through. That's our internal document that we do for self-help. And I'm happy to share that with you if you want more copies. There's more copies outside. I would encourage you to take two, one for your desk at work and one for your fridge at home. The genesis of this document is that it came forward from our VP for provider networking. He brought up the fact that he was concerned about the influence of social media on his college-age children. And he wanted to make sure he had some ways to be able to talk with what can we do from the deleterious effects of social media that don't involve having time to see someone. There's some self-help things that we can do. So I share this with you for yourself, but I'd also share with you, especially having been involved with education, that I think it's very important if you have students that have been through the learning disruption that occurred during the pandemic, please check in with them and please use some of these resources to ensure that you're asking them how they're doing. One of our things as a local health plan is that we like to have a local presence and be involved locally. For our C-suite, the minimum is that you should be on 3 nonprofit boards and be engaged in the community. We like to have that so that we're always trying to uplift ourselves locally. I can't leave here being a former school board member who's been on for 4 years without sharing something with you. If you want to uplift the health of your community, you have to uplift educational and literacy, both financial and health. If you want to do that, you need to make sure that every 5th grader is reading at or above a 5th grade level in your community. Second, you want to make sure that every 8th grader is algebra ready. Those are 2 things I would ask each and every one of you to make sure that you're ensuring is happening with people that are younger than you. Is every 5th grader reading at a 5th grade level or better? And are our 8th graders able to do algebra before they get to high school? Those 2 factors have a direct effect on career trajectory as well as the ability for people to have both financial literacy and healthcare literacy. For us, another focus for Network Health has been social determinants of health, where people live, eat, work, play, travel, and learn. Getting people access to healthy food, transportation, affordable housing, and a living wage is important. We can't do all that as a health plan. However, with our local community involvement, we can start pushing on some levers with community partners that allow us to affect some of those things. I think that's why being engaged locally as a health plan is important for us to do. For those that have an interest in this, I'd also strongly encourage you to read the McKinsey report that talks about global social determinants of health, because the McKinsey report also brings up the absence of war as another social determinant of health. So as we think about that, it's important to think about global health in that respect as well. In closing, I'd like to say that it's important for us to be able to use technology to make human connections that are informed, authentic, and actionable. Thank you very much for your time. I'd be happy to answer any questions. Questions? Looks like everyone's got flights to catch. Yes.
I'm very curious for your frontline staff. What is your model for workforce management, like at home, in the office?
Excellent question. Okay, so my staff is primarily hybrid. I would say that my nurses are probably 100% remote. We have some folks that are coming into the office, but not 5 days a week. All of our VPs and above do come in 5 days a week, just so we have some interaction going on. But I want to expound on this because I think it's important for how we manage culture. Obviously, when pandemic hits, a lot of us had to shift to the whole remote model. We found some successes from doing that, and there was also a certain amount of positives that people found of being able to have that flexibility that exists. The job marketplace for me recruiting is telling me that I can't take that away. So having that is important. The balance that I have to have is to have engaged team members who feel like they feel part of a team. And so what I have found is that we try and do more in-person interactions that are social in nature to be able to do things. If you're a leader, I would strongly encourage you to have birthday lunches with some of your key employees, so that way you have to see someone in person, and so you're able to connect with folks. I think it's also important that we have quarterly leadership meetings as a group for us as well, so we have people getting together that way. But we are, excuse me, primarily remote hybrid, with the exception of probably VP level and above, where most folks are in-house. Yes? I'm sorry, our provider?
How large is your provider network?
How large is it? So we have 7 clinic integrated systems that we work with. We're obviously owned by 2 systems that are going through a marriage right now. And it's been interesting because we try to bring the same quality initiatives forward for these 7 different systems that have different priorities. Some are much more active and engaged. Others think of me as Dr. No. And so I have to kind of navigate some of those waters, and the New York part of Mushir comes out with some systems, and the more friendly Wisconsin Mushir comes out for other systems. Okay, so it depends on the feedback that you get. And so I think that having the trusted foundation of data allows for those discussions to happen. From a numbers standpoint, I would say we're probably at least 1,000 credential providers internally within our plan. So we have the question was, how do we do our STARS work? And if you don't mind, I'm going to get my glass of water. So from a STARS work standpoint, we actually had a STARS task force. And that's been in existence for us since we had, I think we were at 3.5 stars well before I got there. And the task force got set up to kind of get us to 4.5. Meets at least monthly to be able to have a focus on what do we need to fix and what can we do better. Foundationally, what I said about member experience and making sure that we have happy employees talking to members was building block number 1. Building block number 2 was then getting after the quality metrics with our clinician providers. Those are 2 I think are foundational for if you want to improve your star ratings. Those are the 2 big things that you have to do. There are some folks that do some STARS consulting in this way. So if you need someone to kind of get through like a STARS accelerator, those things exist. Those that are part of Health Plan Alliance, that's another opportunity to join there, I think, which is a good thing to do. Yes?
STARS related, so there's going to be a lot of focus on health equity in the future. What's your strategy for that and the measures?
So, excellent. So the question was about health equity and the STARS focus on health equity. We positioned ourselves for developing a health equity foundation for data about 3 to 4 years ago. So we had to start early just to kind of make sure, because we knew we're a rural Wisconsin health plan. So we're predominantly retired farmers that are reasonably well-to-do. From a health equity standpoint, there's probably not as much touch there in terms of some of the metrics that are going to be captured. However, we have moved into southeastern Wisconsin, which is a more urban environment that has more diversity, and as a result, more economic hardships that are present in the community. We needed to first and foremost train our employees about how to talk to folks that don't look like that, and being able to be more sensitive to that. So we had to gather that. With our data team, we had to then also talk about, okay, we are not capturing enough data to be able to report on some of these metrics, so we need to make sure our data sets have those data capture going on as well. So those are sort of the two foundational building blocks that we had. We have kind of a health equity czar, which is a director that helps to kind of run this, because you have to keep up on all these requirements. Then, addition to that, from a quality standpoint, we also have health equity metric reporting, whether it's for breast cancer screening or colon cancer in the specific subpopulations. And being able to get our provider systems to understand how that's important as well is needed. If anyone doesn't understand what I just talked about, feel free to email me and I'll put you in touch with Daryl Landvetter at my organization who walked me through it last week, because it gets confusing. The factor that you have to factor in with depending on how you populate, because first time he explained it to me is, okay, so if health equity patients across health plans all across the U.S. is at, let's say, 48%, and then we have to be at least half of that for our plan to be there, and then take that to factor into what the coefficient, oh my God, okay, now I'm really confused. And that's calculus, okay? Actually, I took differential equations, I just have an engineer, so I still don't understand that. So I had to have Daryl explain to me, okay, show me how this walks through, because I know the doctors are going to ask me this too. So I have to be able to speak to it, to be able to understand how we get there. I can be transparent with you that I know as a health plan, we're probably not going to meet that 22% threshold. And so it's unlikely that we're going to be eligible for any health equity bonus, because our health plan is just, I hate to say it, but simply too white. We insure a lot of rural lives. Other questions? Well, I had a wonderful first week of medical school where someone who was about twice the size of me got to the microphone and he said, first thing he says out of his mouth is, at 11:30, let me assure you, no one in this room is more concerned about getting to lunch than I am. So I don't want to be the obstruction to lunch. I'll hand it off to April at this point then, okay? Thank you.